This session will be recorded so that view the session during your spare time. Okay. For today, which is on general pathology. This is Dr. Tun Matanako, and welcome to our online session. Now, we will be utilizing our standard curriculum here, which is the PASADO program, which is the acronym I've coined for a curriculum, a very specific type of curriculum that we follow in this center, and that is a problem-based analytic systems approach, didactics-oriented curriculum. We will be utilizing the textbook, and we'll be utilizing the most important relevant textbooks, which is associated with the subject matter. Now, the difference is the actual board exam focuses on Bloom's taxonomy, wherein little focus is given on recall questions, memorization. Majority of the questions, at least 60-70%, will be higher level of cognitive learning, which involves analysis, application, comprehension, and evaluation. So for this session, we'll be going over general pathology, which is actually the first couple of chapters from the mother book, which is Robbins. I will be utilizing the following references. And the reason I'm doing cross-referencing is because that's how you score higher in the boards. So the core references that will be used will be the following. So we have Cotran, Robbins and Cotran, pathologic basis of disease. I will be adding some clinical applications lifted from the board review series, or BRS, and a lot of illustrations lifted from the student consult version of Robbins and Cotran. Now, you might be wondering, Doc, our subject is pathology, but why are you inserting Harrison's there? Because of the fact that in the pathology as well as medicine exam, a lot of key concepts were actually cross-referenced. Okay, the subject was pathology, things from Harrison's came out. The subject was medicine, a lot of basic core concepts on the pathogenesis, the morphology of diseases came out. And that is the reason why I'm fusing it, so that you will score higher, you will survive, and you will excel. Hopefully. Okay. Now, we're going to go into the concepts of pathology in general. And when we talk about the core of pathology, there are actually 4 aspects of a disease that forms the core of pathology. This would include causation, which actually refers to the etiology. You will realize later in upcoming post-test practice exams and mock boards that the etiology is almost always asked, or it's almost always included in the multiple choice options. So the first aspect that forms the core of pathology is causation. What is the etiology? What causes a certain disease or disease entity? Is it infectious? Is it chemical or physical agents? Is it genetic or inborn? Or is it acquired? Next is the pathogenesis, which includes both the biochemical as well as the molecular mechanisms. Biochemical as well as the biochemical mechanisms. Now, third core process, which basically forms the core of pathology, is the morphologic changes. What are the associated structural changes that occurs in the cell, in the tissue, in the organ, or in the systems. The last that forms the core pathology is the clinical manifestations. So this includes the functional alterations which occur in both cells and organs. And these functional alterations are actually what leads to the clinical manifestations or the symptomatology. So what did you notice in the core of pathology? It includes, okay, I want you to repeat this to yourself right now: etiology, pathogenesis, morphologic changes, and clinical manifestations. What is not included in pathology, which is included in internal medicine? It is diagnostics and it is therapeutics, or the treatment, as well as prognosis. Okay, now, when you take the actual boards, there's an overlap. That is why our approach will be, when we study pathology, we will already insert the internal medicine so that you know a disease from its etiology, pathogenesis, morphology, clinical manifestations, diagnostics, therapeutics, and prognosis. And what has recently changed in the exam is they now ask about the epidemiology, or the prevalence of the disease. So please be reminded of this. Okay? Again, please be reminded of this. So I hope this is clear. Okay, etiology, pathogenesis, morphologic changes, and the clinical manifestations. These processes form the core of pathology. So a lot are wondering, what is the language which is used in the board exam? Now, allow me to remind you. Morphology, this refers to the green boxes in Robbins. The textbook is color-coded. There are green boxes there, which would basically refer to the morphology. Okay? The key concepts, which is the clinical manifestations, this comprises the blue boxes in Robbins. That is why this is actually one of the subjects you can predict. One of the subjects you can crack wide open. In fact, this was one of the best subjects we had from the last exam. Okay? Now, the catch. Prepare for overlap. Okay? So I hope this is clear. Now next, there is this infamous figure from your textbook, which describes the different stages of cellular response to stress as well as injurious stimuli. So a cell, under normal circumstances, is at a state of homeostasis. Everything is balanced. However, when a cell is exposed either to stress or injurious stimuli, that cell can either adapt or that cell will be injured. Now, when that cell cannot adapt, that's where the cell injury comes in. And a cell injury can either be reversible or irreversible. So if that cell injury is mild and transient, then that is a reversible injury, which will go back to cellular homeostasis. But if the cell injury is severe or it is progressive, then that injury becomes irreversible. And there are only two pathways for irreversible cell injury. That includes necrosis, which is the sum of all cellular death, or apoptosis. Now, question. These are the two types of cellular death, necrosis and apoptosis. My question is very simple. Which is associated with programmed cell death? Which is associated with programmed cell death or programmed cellular death? Okay, very good. It is apoptosis. There are cells that have a time limit. They have a lifespan that once they reach this number of days, number of hours, or number of weeks, our body will now trigger such cellular mechanisms that that cell will die. Okay, so that is the programmed cell death. Okay, now what I want everyone to remember here is we need to know which is irreversible, which is reversible. Okay, now let's proceed. I lifted this statement verbatim from the mother textbook. Allow me to read it. If the limits of adaptive responses are exceeded, nasobrahan, nalampasan, or if a cell is exposed to damaging insults, or the cell is deprived of critical nutrients, or there are mutations, what will happen? Cellular injury. Okay, again, if the limits of adaptive responses are exceeded, or the cell is exposed to damaging insult, nutrients are depleted, mutations occur, then cellular injury will happen. Now, everyone, please make sure you input this in your hippocampus. What are the two principal pathways of cell death? Necrosis. Then we have apoptosis. Okay. Now, let's go back to the concept of cellular injury. Cellular injury can be caused by several things. One, hypoxia, physical, chemical agents, as well as drugs, infectious agents, immunologic reactions, genetic derangements, as well as nutritional imbalances. Now, basic standard question. Which of these causes is the most common cause of cell injury? Which is considered to be the most common cause? Sige, may 1 point ka na sa exam. It is hypoxia. Hypoxia is the most common cause of cellular death. Okay? Now, allow me to insert lang before I forget. Later tonight, everyone will receive some instructions, a schedule, a checklist of videos to finish for the first phase, a set of links to post tests. So what we're going to do is we're going to beef up the curriculum that after every 1 to 2 sessions, live sessions, as well as assigned asynchronous sessions, you will have a post test, 10, 15 items online, unlimited access, pwede pabalik-balik. The post test will have rationalizations, and you are encouraged to repeatedly take the exam until you get it perfect before you go to the mock boards, which are graded. Okay? I hope this is okay with you guys. Okay lang ba? That we're going to modify and enhance the curriculum so that at the end of the day, let's just say everyone gets the best chance at improving themselves, and everyone gets the best chance at mastery. Okay? Because what we want here is no one left behind. Okay? So let's go back. So I hope this is clear, the causes of cellular injury. Okay? Now let's isolate hypoxia. This is considered to be the most common cause of cellular injury. Okay? It is considered to be the most common cause of cellular injury. Okay? Now, what I want you to remember is hypoxia is simply defined as the deficiency of oxygen. Okay? And what I want everyone to remember is that when there is a deficiency of oxygen, the cell will fail to produce ATP, which is the required energy currency. And this is derived from a process known as aerobic oxidative respiration, or in biochemistry, what we call the electron transport chain, or the ETC. Now, question. Which complex of the electron transport chain, okay, is inhibited by cyanide? Which complex of the electron transport chain is inhibited by cyanide? Okay, it is complex 4. And complex 4 is cytochrome oxidase. Okay, don't forget, aside from cyanide, carbon monoxide, which has a higher affinity for oxygen, okay, also inhibits complex 4 of the electron transport chain. Now, these are the major causes of hypoxia. Ischemia is the most common. Okay, so let me repeat. Let's make sure everyone on board gets this. What is the most common cause of cellular injury? What is the most common cause of cellular injury? The most common cause of cellular injury is hypoxia. Follow-up question. What is the most common cause of hypoxia? Okay, the most common cause of hypoxia is ischemia. So when you say ischemia, it simply means the arterial blood flow is decreased. Venous outflow can also be decreased. And what is responsible? Okay. What is responsible for causing ischemia? Number one cause is atherosclerosis. Okay. Atherosclerosis is the most common cause of ischemia. And what happens with ischemia? So my question is very simple. What is ischemia? Is it reversible or is it irreversible? What is ischemia? Ischemia is still considered to be reversible. However, when ischemia is not reversed or corrected, it becomes an infarction. Okay, which is actually already a form of necrosis. Ischemia can be caused by thrombosis as well. Now, allow me to give you a board recall on thrombosis. Now, there is a triad of stasis, vascular wall injury, as well as hypercoagulability. Question: what do we call this triad? What is this famous triad, which is characterized by stasis, vascular injury, and hypercoagulability? Okay, great. This is known as Virchow's triad. Okay, this is Virchow's triad that is associated with thrombosis. Now, another clinical application to your boards, which is associated with thrombosis. Okay, now, clinical application. You have a patient, let's say there's a 25-year-old patient, okay, who was diagnosed with hepatitis C. Okay, she develops cirrhosis. Okay, so this age group, you'd probably think this is a vertical transmission of hep C or from blood transfusions. The patient develops thrombosis specifically of the hepatic vein. So this patient now has ascites. What do we call this syndrome? Thrombosis of the hepatic vein, or venous or hepatic vein thrombosis. This syndrome, which usually presents with ascites, what do we call this syndrome? This is known as Budd-Chiari syndrome. Okay, Budd-Chiari or Budd-Chiari syndrome, okay, presents with ascites, and it occurs as a result of hepatic vein thrombosis. Okay, so I hope this clinical correlation is clear. Now, another cause of hypoxia is decreased carrying capacity of oxygen. That's the decreased carrying capacity of the blood. And you see this in patients who are anemic. Okay, so please remember this. Now, allow me to share this table lifted from your Robbins. Okay, cellular response to injury. So I want to go straight to what we just mentioned. Reduce oxygen supply. This can either be acute, this can be transient. And the cellular response, okay, will either be hyperplasia, hypertrophy, atrophy, metaplasia, dysplasia, until you get cancer. And another cellular response, which eventually leads to death, is either going to be necrosis or apoptosis. Okay, I just want to quickly highlight that. Now, what about the cellular changes that occurs during an injury? So number one, you have the free radicals, such as hydrogen peroxide. Free radicals will cause peroxidation, and this peroxidation leads to cellular death. Okay, now question, what is the famous enzyme, okay, which is associated with free radicals? A free radical formation, or what we call ROS, or the reactive oxygen species. What is that enzyme aside from the peroxidases? Give me one famous enzyme, okay, aside from the peroxidases. Okay, this is what we call SOD. Can anyone tell me what the meaning of SOD is? What is that enzyme? SOD. That is super oxide dismutase. Okay, now allow me to share a PLE recall, which a lot of students complain, bakit daw lumabas? My answer is simple. It's in the book. Okay, so they mention death of the anterior horn cells. And they mention the role of superoxide dismutase as well as excess of glutamate. Question: what is this disease? Presents with death of the anterior horn cells. What plays a role here is excess glutamate and the enzyme superoxide dismutase. Okay, very good. This is ALS. Okay, what is the meaning of ALS again? It means amyotrophic lateral sclerosis. And that is also known commonly as Lou Gehrig's disease. Okay, that is also known as Lou Gehrig's disease. Okay, now another cellular change that occurs is the depletion of ATP, followed by increase in the permeability of the cell membrane, and of course, the influx of calcium. Take note, it is influx, not efflux. So what happens when calcium comes in? There's going to be activation of enzymes. One of these enzymes would include phospholipases, peroxidases, phospholipases, peroxidases. So let's recap. What are the key words for the cellular changes during injury? 1, free radical formation. 2, ATP depletion. 3, increase membrane permeability. 4, influx of calcium. Okay, so please take note of this. Now, these are the must-know enzymes you need to remember by heart. Okay, number 1, we have proteases. Number 2, we have ATPases. Okay, proteases. Then we have phospholipases. Then we have the endonucleases. So what are the 4 enzymes I want you to remember? Proteases, ATPases, phospholipases, okay, and endonucleases. So please remember this by heart. Proteases, ATPases, phospholipases, and endonucleases. Now, the phospholipases are the ones responsible for the cellular injury. Okay, the cell membrane injury. The endonucleases are the ones that damage the DNA. Okay, they damage the DNA. So please take note of that. Okay, they damage the DNA. So I hope this is clear. Now, what about the physical agents? Okay, there are physical agents which can cause cellular injury. Okay, number 1, we have mechanical trauma. Okay, we have mechanical trauma. We also have extremes of temperature, which can include cold, deep cold. This can be associated with frostbites. Then we have burns. Okay, we have burns. Then we have sudden changes in atmospheric pressure. Then we have radiation. Then we have electric shock. Okay, radiation and electric shock. Now for the chemical agents, very specific in 10th edition of Robbins. Half of what I'm showing you here is not seen in the 9th edition. So they now specify the arrangement of electrolyte and fluid balance, which is associated with glucose and salts. They mention trace poisons like arsenic, cyanide, and mercury, environmental pollutants, which is a separate chapter in Robbins, which is under environmental pathology. There's now the mention of insecticides and herbicides, as well as industrial and occupational hazards. Asbestos is mentioned, cyanide, and recreational drugs, which now includes alcohol, which of course is the most common cause of fatty change in the liver, followed by dyslipidemia or hypercholesterolemia. Okay? So please take note of this. Okay? Now, I want everyone to take note of this. I'm going to mention a buzzword. Let me know whether it's arsenic, cyanide, or mercury. Minamata disease. What is Minamata disease? Is it arsenic, cyanide, or is it mercury? Okay, very good. It is mercury. Okay, Minamata disease is mercury poisoning. Okay, Minamata disease is mercury. Okay, now, question. Your choices is either arsenic, cyanide, or mercury, which is associated with the Mies lines. Okay. Okay, Mies lines. This is arsenic. Okay. Mies lines. This is arsenic. Okay. Now, let's see who's going to top the exam. What mineral is deficient in Kishan's disease? Okay, what mineral is deficient? Okay, very good. It is selenium. Can anyone tell me what virus is mentioned in Robbins, which is associated or implicated for Kishan's disease? So Kishan's disease usually presents with cardiomyopathy as a result of a deficiency in selenium. Kishan's disease. So this is usually associated with Coxsackie. Okay, this is associated with Coxsackie virus. Okay, and yes, it is correct. It is Coxsackie B. Okay, Coxsackie B. Okay. Coxsackie B is the one associated with the Coxsackie B is the one associated with cardiomyopathy. This is under the chemical agents. Now, under infectious agents, okay, under infectious agents, they can either be a bacteria, they can also be virus, they can also be a parasite, and it can also be a fungus. Okay, so please be reminded of that. Immunologic reactions, it can be autoimmune. Okay, it can be an autoimmune. It can be immune mediated, or you can even have an immune deficiency. under genetic aberrations. So this is mentioned in your textbook. They mention Down syndrome, which is trisomy 21. And they mention sickle cell anemia. Now, question. What are the 2 amino acids involved in sickle cell anemia? What are the 2 amino acids involved? Okay, there's a substitution of the amino acids. So we have valine and we have glutamic acid. Okay, valine and glutamic acid. These are the 2 amino acids which are substituted in sickle cell anemia. So this is a form of a point mutation. It's a point mutation. So please take note of that. Now, nutritional imbalance. Nutritional imbalance can also cause cellular injury. We have the protein caloric deficiency. We have vitamin or nutritional deficiencies. Obesity is a nutritional imbalance. Anorexia nervosa is also nutritional imbalance. Now, question. What is kwashiorkor? Is this protein or is this caloric deficiency? Protein or caloric deficiency? This is protein. What about marasmus? This is predominantly caloric deficiency. Okay? Predominantly caloric deficiency. So please take note of that. Now, question. What nutritional deficiency, what vitamin deficiency, okay, is associated with pellagra? What vitamin deficiency is associated with pellagra? Okay, so this is associated with niacin, or what we call B3 deficiency. And don't forget, this is also associated with the deficiency of the amino acid tryptophan. Now, what vitamin deficiency is associated with burning foot syndrome? What vitamin deficiency is associated with burning foot syndrome? Burning foot syndrome, this is B5 or pantothenic acid. Okay? B5 or pantothenic acid. B5 or pantothenic acid. So please remember that. Okay, B5 or pantothenic acid. So I hope that is clear. Now, moving on. PLE recalled. What are the 2 features consistently seen in reversibly injured cells? Okay, so the 2 features which are consistently seen in reversibly injured cells. Okay, number 1 is the cellular swelling. Okay, there's swelling of the cell, there's swelling of the organelles. Number 2, there's fatty change. Okay, now, for those who want to top the exam, what is the disease that presents with a microvesicular fatty change of the liver after a child with a viral infection takes aspirin? Okay, so the case scenario, you have a child with a viral infection. They ingest aspirin and they develop a microvesicular fatty change of the liver. This is the famous Reye syndrome, or just pronounce it as Reyes syndrome. So I hope this is clear. Okay, Reye syndrome or Reyes syndrome. Now, the other term for generalized swelling, we often call this hydropic change. Okay, we call it hydropic. It's because the sodium potassium ATPase pump will be deranged. And what happens when there's derangement of the sodium potassium ATPase pump? Water will come in and the cell will swell. Now, the Robbins green boxes, which refers to the morphology. Possible question in your post-test and mock boards. What is the earliest manifestation of cellular injury? What's your answer? I want it to come from you so that you will never forget it. The earliest manifestation of cellular injury. The earliest manifestation of cellular injury is cellular swelling. And what is the pathologic term again? What is the pathologic term of cellular swelling? Okay, this is also known as hydropic degeneration, okay, or hydropic change. Okay, so microscopically, you're going to see the hydropic change or the vacuolar degeneration. Please remember this by heart. Okay. You are actually going through the textbook. If you get the chance to read it yourself, you'll have a big smile on your face. Now, allow me to share this figure from our text. This is the sequential development of biochemical as well as morphologic changes in cellular injury. Biochemical and morphologic changes in cell injury. So this is the effect here on the vertical axis. On the horizontal axis is the duration. Gaano katagal. So the longer the injury is, biochemical alterations will occur, which eventually can lead to cellular death. Ultrastructural changes occur, as well as slight microscopic and gross morphologic changes. So the dictum is this. Once there are already alterations, biochemical, structural, morphologic, that is the border between reversibility. Okay? So please remember that. Now, I made a table in your handouts differentiating the reversible and irreversible cellular changes. I want you to read on that. Now, let's highlight apoptosis. Okay, again, let us highlight apoptosis. This is a specific type of cellular death that has what we call a well-regulated suicide program. What does that mean? Okay, there are cells that are destined to die. And always remember that these cells which are destined to die, they will activate certain groups of intrinsic enzymes that will degrade the cell's genomic DNA, as well as the proteins of that cell, which are comprised of DNA as well as nuclear proteins. Are you familiar with Mission Impossible? Let's use Tom Cruise. What is that message which is stated after he receives a mission? Can you remember the phrase? Okay. That Tom Cruise in Mission Impossible will hear after he is oriented or told about a mission. There's that phrase that this message will self-destruct. Okay, that is a similarity to apoptosis. Okay, that is a similarity to apoptosis. This message will self-destruct. Okay, ganon yung apoptosis. So this is the famous programmed cell death. Okay, now I would like to mention that in the process of apoptosis, there has to be proper protein folding. My question is this: what is responsible for the proper folding of proteins? We call them chaperones. The chaperones are responsible for the proper folding of proteins. Proper folding of proteins. The chaperones. I hope everyone memorizes this by heart. Now, must knows, must bring to the boards. Okay. The new edition of Robbins mentions the apoptotic bodies. These are actually fragments of the plasma membrane. Apoptotic bodies. These are plasma membrane fragments. Now, another thing I want you to know is that we have pro-apoptotic agents and we have anti-apoptotic. The pro is the backs, the bad, and the back. They are pro-apoptotic. They promote apoptosis. The anti-apoptotic isa lang, that is BCL2. It is mandatory for you to memorize that. Okay? Now, the two causes of apoptosis is either going to be physiologic or pathologic situations. Okay, physiologic or pathologic situations. So here, just to visualize, now, you are studying for the boards. What would you memorize or bring with you? The pro or the anti? Let's see if you are street smart. Okay, memorize the anti. Why should you memorize the anti? Come on, be street smart. Why should you memorize? Okay, you should memorize the anti. Okay, because it's only one neuron lang. There's only one. Okay. So this is the mnemonics here. Backs back are the bad genes. Okay. Bad back are the bad genes. Okay. Bad back are the bad genes. So please remember that by heart. Now, the green box. Morphology again. Okay. I want everyone to remember these 4 morphologic features that cells will undergo during apoptosis. What are these 4 morphologic features? Number 1, there is shrinkage of the cell. The cell will shrink. Number 2, okay, there is condensation of the chromatin. There's the formation of the cytoplasmic blebs, the formation of the cytoplasmic blebs, and we mentioned the apoptotic bodies earlier. Okay, the membrane fragments, and lastly, there's phagocytosis of the said apoptotic cells or bodies. And this phagocytosis is facilitated by the macrophage. So please remember this by heart. Okay? Now, necrosis. This is the last part. Give me a thumbs up if you're still with me. Kaya pa? Okay, at least I'm not alone. Kaya pa ba? Okay, so let's mention necrosis. Now, the previous definition in Robbins was the sum of all cellular death. This has now been revised to the spectrum. Okay, it's a spectrum of morphologic changes that follows cellular death in a living tissue. Now, question, is necrosis reversible or irreversible? What is necrosis? Is it reversible or is it irreversible? Okay, perfect. Necrosis is irreversible. And what are the two permanent cells? Okay, these are the cells in the body that do not regenerate. What organs are these, or what two cells? Number one is the neuron. Okay. Number two is the cardiac myocyte. Okay. The heart and the brain do not regenerate. So once they undergo necrosis, clinical application, myocardial infarction, you will see scar tissue. Ischemic stroke, where you have a cerebral infarction, you will see scar tissue in the brain because they are permanent cells. Okay? Unlike cells that are quiescent, or cells that can regenerate, like the renal tubules, okay, the nephron can regenerate, the hepatocyte can regenerate. But once the hepatocyte reaches a point of cirrhosis, that is already irreversible. Now, I want to show you this figure. Ganda. Here's the normal cell under homeostasis. We mentioned that a cell can adapt, the cell can recover, and the cell goes back to normal homeostasis. When there's reversible injury, what again is the earliest manifestation? It's swelling of the cell. Now, aside from swelling of the cell, there's also swelling of the endoplasmic reticulum in the mitochondria. Do not forget the endoplasmic reticulum is where protein synthesis occurs. And you have to be specific that that is the rough ER. The mitochondria is the powerhouse. That is where ATP and oxidative phosphorylation occurs. Then we have the formation of myelin figures. We have membrane blebs. The injury progresses, okay, until there's breakdown of the plasma membrane, leakage of nuclear contents, then necrosis occurs. This is now irreversible. Okay, now I would like to highlight this figure from Robbins. We mentioned ischemia as the most common cause of hypoxia. And we mentioned that oxidative phosphorylation, which occurs in the inner mitochondrial membrane, would decrease. Decrease in oxidative phosphorylation would result to a decrease in ATP formation. So what happens here? Take note of these series of events. Dysfunction of the sodium-potassium pump. Increase in anaerobic glycolysis, which of course the product will now be lactic acid. The ribosomes will now detach. So what happens biochemically? There's going to be a decrease in protein synthesis. Why is there a decrease in protein synthesis? Because the ribosomes are detached. There's going to be increase in lactic acid. Why is there an increase in lactic acid? Because there's an increase in anaerobic glycolysis. And we mentioned the influx of calcium, which leads to cellular death. Okay, so please take note of this. Okay, now this one came out. What is the major mechanism of apoptosis? Okay, what is the major mechanism of apoptosis in mammalian cells? What is the major mechanism of apoptosis in mammalian cells? Okay, so it is the mitochondrial pathway. Okay, the mitochondrial pathway. So please take note of that. Okay, so this is that mitochondrial pathway. So I want everyone to remember that. I just want to highlight here that protein misfolding, DNA damage, dysfunctional chaperones, this leads to the activation of pro-apoptotic proteins. What are the three pro-apoptotic proteins again? Let's check your immediate recall. What are the three pro-apoptotic? Okay, we have the BAD, the BAX, okay, and the BAC. Okay, very good. Now, I want everyone to memorize this. Okay, I want everyone to memorize this. So I hope this is clear. There are 3 diseases highlighted in the textbook. Okay, 3 diseases highlighted in the textbook, which results from protein misfolding: Alzheimer's, Parkinson's, and Huntington's. Question: which of these 3 diseases is associated with a trinucleotide repeat of CAG? Trinucleotide repeat of CAG. Okay, very good. It is Huntington's disease. Okay, it is Huntington's disease. Okay, now we will go to the last part. Okay, so first, let's mention hypertrophy. Okay, hypertrophy. Okay, hypertrophy is defined as an increase in the size of the cells. Okay, and this increase in the size of the cells results to an increase in the size of the organ or tissue. Hypertrophy can either be physiologic or pathologic. Okay, physiologic, like uterine muscle hypertrophy, seen in pregnancy. Pathologic, like in left ventricular hypertrophy, seen in chronic hypertension. So hypertrophy results from gene activation and protein synthesis. Hypertrophy is also associated with the production of organelles. Okay, so gene activation, protein synthesis, and the production of organelles. Now, I want to share this figure from the previous edition of Robbins, which uses the classic example of hypertrophy, yung LVH, or the left ventricular hypertrophy, which is seen in patients who have chronic hypertension. Okay, so that is LVH. Here is the physiologic hypertrophy of the uterus. Okay, the physiologic hypertrophy of the uterus. So please take note of this. Okay. Please take note of this. So I hope this is clear. So physiologic hypertrophy of the uterus, that's physiologic, pathologic, okay? Pathologic is hypertension, okay? So I hope this is clear. Okay. Now stretch while you can. Now hyperplasia, on the other hand, okay, involves the production of new cells. So what do we call the specific stem cell that has the capability of developing into multiple types of cells? Multiple types of cells. Okay, we call them, very good, we call them the pluripotent stem cells. Okay, the pluripotent stem cells. Now, under hyperplasia, this is lifted from your book. Okay, we have physiologic, and we have pathologic hyperplasia. Okay, physiologic, then we have pathologic hyperplasia. Now be careful, because it is the pathologic hyperplasia which can progress to dysplasia. Dysplasia can progress to cancer. Please take note of this. So under physiologic hyperplasia, I want you guys to take note, okay, that this includes pubertal changes. Okay, this includes pubertal changes, so such as the breast enlarging. This also includes the pregnant uterus, as I mentioned. And this also includes in the new edition, erythroid hyperplasia. The reason that is highlighted is because that is what came out recently. Okay. Okay. Now, under pathologic hyperplasia, I want everyone to remember this. Okay. Under pathologic hyperplasia, okay, please take note. We have the classic example of endometrial hyperplasia. Okay, so especially in a middle-aged woman with, let's say, presenting with vaginal bleeding, okay, please take note that this is considered pathologic. Okay, this is considered pathologic. Now, the exception to the pathologic hyperplasia here would be BPH, or benign prostatic hyperplasia. Now, I have a question. What is the enzyme that converts estrogen to testosterone? What is the enzyme? Anyone? Okay. What is that enzyme? Okay. So the enzyme aromatase, take note, plays a very important role in converting your androgens. It plays a very, very important role in converting your androgens. So you have there the conversion, okay, of testosterone, baliktad, testosterone to estradiol. Okay, testosterone to estradiol. So please be reminded of that. Okay. Testosterone to estradiol. That is aromatase. Okay. So I hope you got that. Okay. Now, this is what I want you to bring with you. If your exam is, let's say, 5 minutes from now, okay, if your exam is 5 minutes from now, take note of physiologic hyperplasia. Okay. The liver donation is there, huh? Now, I want everyone to memorize this by heart. Okay. Hyperplasia cannot occur in the following tissues. A hyperplasia cannot occur in the following tissues. Number 1, cardiac. Number 2, skeletal muscles. Number 3, okay, the neuron. Okay, please remember this by heart. Okay, again, please remember this by heart. The 3 tissues where hyperplasia cannot occur: cardiac, skeletal, and the nerve. Of these 3, it is the cardiac and the nerve which are considered to be permanent cells. Okay, now atrophy is defined as the shrinkage of the cell. Okay, so the size of the cell becomes small, and this mechanism of atrophy occurs via a decrease in the size and the number. So please remember this. Okay, so this is for atrophy. Now, the mechanism of atrophy, basically, please take note, is associated with apoptosis. Okay, and this is a decrease in the cell number. Okay. There's also a decrease in the cell size. So the decrease in cell number is based on apoptosis. The decrease in cell size is by 2 mechanisms which you need to memorize: the ubiquitin proteasome degradation and autophagy. Okay, again, what is the mechanism in the decrease in the cell number? I want to hear it from you. Decrease in the cell number. Okay, it is apoptosis. And what are the 2 mechanisms which is associated with a decrease in the cell size? Okay, it is ubiquitin proteasome degradation. Then we have autophagy. Now, there is a very important enzyme. It's actually mannose 6-phosphatase, which is associated with autophagy. This one came out in the boards. Question: what disease is associated with a deficiency in mannose 6-phosphatase or mannose 6-phosphate? What disease? Okay, very good. It is eye cell disease or inclusion disease. Okay, eye cell disease or inclusion disease. I want to highlight this. Okay, this is from the 9th edition because they use the description in the figures. This part here: loss of brain substance, widening of the sulci. Those exact words. This is atrophy. Now, question: what is the famous neurologic disease which is characterized by atrophy, okay, of the brain, which is defined as widening of the sulci, narrowing of the gyri, and the loss of the brain substance? So we have Alzheimer's disease. But I want everyone to remember that in Alzheimer's disease, aside from the generalized brain atrophy, there is the formation of what we call the neurofibrillary tangles. Okay? The neurofibrillary tangles. And there's also the amyloid plaques. In neurofibrillary tangles, then you have the amyloid plaques. Okay, so please remember this by heart. Neurofibrillary tangles, we have the amyloid plaques. Okay, I hope this is clear. Neurofibrillary tangles and the amyloid plaques. Please jot this down. For atrophy. Now, metaplasia, on the other hand, this is a reversible change wherein one cell type, okay, is replaced by another. Now, the classic example here, okay, the classic example is going to be either a squamous metaplasia, a cuboidal or columnar metaplasia, and what usually comes out in the boards, okay, what usually comes out in the boards is a famous condition associated with GERD or gastroesophageal reflux disease, wherein the esophagus from a stratified squamous epithelium changes or is replaced by simple columnar. What do we call this condition? Okay, very good. This is Barrett's esophagus. Now, according to Robbins, the hallmark of intestinal metaplasia is the presence of intestinal goblet cells. Okay, the hallmark of intestinal metaplasia. The hallmark of intestinal metaplasia is the presence of intestinal goblet cells. So here we have the presence of goblet cells. Now I want everyone to remember Barrett's esophagus. The predisposing risk factor here is GERD. Okay. Question. What is the most common type of cancer associated with Barrett's esophagus? What is the most common type? Okay, very good. The most common type of cancer, esophageal cancer, associated with Barrett's is adenocarcinoma. Okay, it is adenocarcinoma. Okay, so it's a precursor of adenocarcinoma. Now, I just want everyone to remember this. Ito yung board recall na lumabas. A lysosomal storage disease with defective phosphotransferase. So as a result of a defective phosphotransferase, there's no production of mannose-6-phosphate. And we mentioned earlier that mannose-6-phosphate is associated with what mechanism? Autophagy. Okay? It is associated with autophagy. Now, lastly, let's go over the morphologic types of necrosis. These are the general types, morphologic types of necrosis. We have coagulative, liquefactive, cassation, and we have fat necrosis, followed by fibrinoid and gangrenous necrosis. Now, let's go over each one. In coagulative necrosis, the cellular architecture is preserved. We have the presence of the ghost cells. In fact, coagulative necrosis in some references is known as tombstone necrosis. Okay? Coagulative necrosis occurs in solid parenchymal organs, such as the heart, the spleen, and the kidneys. So when there is an infarct of these solid parenchymal organs, it is associated with coagulative necrosis. Question: what is the solid parenchymal organ that, when infarcted, does not undergo coagulative necrosis? Instead, it undergoes liquefactive necrosis. Okay? It is the brain. Okay? The brain undergoes liquefactive necrosis. Okay? So please take note of this. Now, here are some photos. Here is a renal infarct, wedge-shaped white infarct. The black arrows here shows you the heart. This is an infarct in the left ventricle, usually associated with underlying coronary artery disease. Then we have liquefactive necrosis, where you have the presence of enzymatic reactions which liquefies the tissue. Okay, so this can be in the form of an abscess or pus, pleural effusion, or the brain. What will come out here in the boards is the brain, okay, a liquefactive necrosis. Then we have a photo here. Yeah, and that's the liquefactive necrosis of the brain. And a microscopic finding: normal brain is here on your left. On the right is the infarcted brain. This area here already shows the liquefaction. Okay? Now, next is the cassation necrosis. Cassation necrosis is usually characterized by the presence of lysed cells surrounding inflammatory cells. This is known as the cheese-like friable material, and this is usually associated with tuberculosis. Now, can anyone tell me what substance is responsible for cassation necrosis in tuberculosis? What substance? Okay, so we have the presence of the phosphatides. Okay, the phosphatides are responsible for the cassation necrosis. Okay, again, the phosphatides are responsible for the cassation necrosis. Okay, now here, pointed by the black arrows, that's your area, your foci of caseous necrosis. Okay, surrounding are your lymphocytes, are your inflammatory cells, and grossly, you have here the cheese-like material. This is tuberculosis, which loves the apex of the lung. Okay. Then, of course, we have fat necrosis, okay, which can occur in the following organs: adipose, okay, the pancreas. Now, fat necrosis is associated with enzymatic digestion. Okay, by enzymes such as phospholipases, okay, amylases. These are the common enzymes, okay, as well as proteases. Okay, these are responsible for enzymatic fat digestion. Now, there is something which happens particularly in the pancreas, like when you have pancreatitis. Okay, pathologically, there are areas of chalky white deposits, and this is because of the formation of calcium soap. This is what we call saponification. Okay, now, question. What is the most common cause of acute pancreatitis? What is the most common cause? Acute pancreatitis. Okay, acute pancreatitis is gallbladder stones. Okay? Gallbladder stones, yung acute pancreatitis. Chronic pancreatitis. Chronic pancreatitis is alcoholism. Do not mix them up. Okay? So please remember that by heart. Okay? Some photos. So acute pancreatitis, enzymatic fat necrosis, and here, the chalky white deposits that you see here. Okay? This is what we call the saponification. Then we have fibrinoid necrosis. Okay? We have fibrinoid necrosis. Okay? Which we usually see in vasculitis. Okay? In blood vessels. This is the same mechanism or form of necrosis you see in graft versus host rejection when the blood vessels are going to be rejected. Okay? So this is fibrinoid necrosis. You also see this in malignant hypertension, wherein there's classic onion skin appearance. Okay, onion skin appearance in malignant hypertension. After we finish the class, syncytium, stay behind. And if there's any of you who came in late and want to catch the front part of the session, please stay behind. Okay? So I hope this is clear. And make sure everyone signs the attendance because these will be forwarded to your respective chief of clinics. For Einstein, Newton, and Gates, that will be forwarded to your chief of clinics, Dr. Toon. Okay, so the classic microscopic description in malignant hypertension is the onion skin appearance. Okay, and lastly, the gangrenous necrosis. Gangrenous necrosis is usually associated with vascular occlusion. Okay, as well as ischemia of the limbs, which is very, very common in diabetics. Now, this is also seen in smokers. We have a specific gangrene. Okay, it's actually a peripheral arterial occlusive disease. Okay, what do we call that disease? Okay, we call that Berger's disease. Okay. That's angiitis obliterans. Seen in chronic heavy smokers. That's for the gangrene. Now, gangrene by classification can either be wet, okay, or it can be dry. What you see here is the dry, okay? So please make sure everyone downloaded the study guide. I will re-upload it here in the chat box. I will also give you a copy of the recording, and I will also give you a link to the post test after 48 hours. Okay? Are there any questions? Feel free to chat it in the chat box if you have a question. So syncytium, stay behind. We'll do the front part of the session that we missed. And anyone who came in late or simply wants to go over it again. If you have finished already, then you can be dismissed. Head back to your classes or whatever the case may be. Okay? So I hope you got something. You basically dissected the textbook. Okay? So you can quietly leave while syncytium and the others stay behind.